Okay.
Cool. And Kashima, I saw that you were able to submit your discussion board, so I will check it probably this weekend and grade it, and you should be good to go. So I did add something to the course content. Now I know Kashima, you're driving. I don't want you to pay attention to this. Like, be safe. That's the most important thing. But if you can, Chandra, pull up. So under the course, I don't even remember where I put it. Under the course, under course content, I've added a new folder.
Can I do this while I got you on here?
Totally. I'm going to
Okay.
share the screen, but if y'all want to follow along with like your own copy.
Oh, wait
So
a
when you
minute.
go under course content, there's now a new folder at the very top called counseling techniques. So these are some of the things that we're going to talk about, or some of them we've already talked about, that are going to be things that you're going to want to familiarize yourself with and possibly incorporate whenever you start running caseloads, whether it's individual, whether it's group. So every week until the end of the semester, I'm going to spend some time at the beginning and just kind of introduce or reintroduce ourselves to these things and just kind of talk about them so
Okay.
what they are. But so you've got two documents. The first one is counseling techniques. So when you open it up, it's got cognitive behavioral therapy, motivational interviewing, just various things like that we'll kind of go over. But what I want to focus on today.
Are you talking about module 3?
It is no, it's under course content. Like it's at the very top. Like as soon as you click on it, it's not in a module folder.
Counseling techniques?
Counseling techniques.
Yeah, okay.
And then so there's a document that says, unconditional positive regard.
Yes, yep.
So I'm not going to read through all this stuff. But who have you heard of? I refer to it as UPR, but have you heard of UPR before?
Hang on, let me take a look at it because I
Well,
have heard of unconditional positive regard, but let me look and see what this. Oh darn, I almost opened the wrong file. Okay.
So you should be able to see it on the screen.
Yeah.
So essentially what UPR is it's more of an approach and also like a mindset. It's not necessarily, I mean, it can be like a specific technique, but it's important to know because as the name implies, like it's basically a client-centered approach that has to do with, regardless of what the client is or thinks or does, our job ethically as a clinician, as a helper, is to regard them positively. So I think I might have shared this a couple weeks ago or during the first of the semester.
This was okay, I took this class with Rihanna, like she covered this in one of her theories of counseling.
Cool. So this is just going to be a recap. Like I said, this isn't even in one of the modules. I just was kind of thinking about what are some more interesting things we could talk about. And even for me, like I just wanted to go back to the basics because this actually for me, UPR was pretty fundamental in getting me to kind of like switch because I did a lot of things the wrong way whenever I first started. Granted, as I've said before, like you're not going to get a lot of training. We had like my organization had like a 2-week little positive recovery university, but no one is going to sit down and hold your hand and be like, hey, I'm going to walk you through every way and teach you how to be a counselor. Like you're going to have support and people that are going to mentor you and supervise you. But in terms of like, you're going to figure a lot of this out in real time.
Yeah,
And so
and I'm
go ahead.
sorry. I'm really glad that you're bringing this up because I started my practicum and I'm finding that like my mind like is wandering when people are sharing. Like they're coming up with all these wonderful ideas and I'm shadowing somebody right now in LCDC. And she's the lead counselor. And in my mind, I'm thinking like, and she's just going, okay, all right, great, okay. And I'm thinking, oh my gosh, like, whoa, like they're talking about opening up companies and, but she's like having this, a little bit of this, not
Yeah. And so,
judgmental and supportive and because part of me wants to say like, hey, whoa, like let's stay in the here and now and you know, work on your sobriety first, but she's not doing that. So
And there might be intention behind it. Like I tend to be that kind of a counselor. Like I just trained somebody from our San Antonio location that spent a couple weeks down here and shadowed me. And this individual came from a more of a like they came from a methadone clinic. So it was very case management, very hardcore. So it was a lot of like calling people out on their shit and kind of like nipping things in the bud. Now there is a time and a place for that, but ultimately like to continue to build rapport and to encourage, because if like let's say it's day one and somebody comes in with some BS, and which is going to happen, you know, there's a lot of BS that comes from being in addiction, manipulations and denials and rationalizations, and you're going to see it and you're going to want to jump on it right away. But if this is like your first meeting with the client and you shut them down, you damage rapport and they're not going to come back. You know, you want to encourage them to explore things and then kind of build the skill of noticing when it's appropriate to jump in, like whether somebody's talking too long, whether they're disclosing inappropriate details, whether they are kind of veering too off in the course. But that's a skill. Like that's a skill that you have to build.
no, I
And
noticed
the
this
way to
is like
build
way
that is you
harder.
just have to let it happen. You just have to like kind of put your instincts aside and kind of come into it as an observer and like let things kind of play out. And then slowly, I wouldn't start addressing things right away, you know. So on UPR, I think I shared the story about one of my first clients within my first year was this old, mean, grumpy, racist white dude. You know,
Yes,
he was like
you
an
did.
old biker, and he just loved telling me he did it. Thank God he did it behind closed doors, but he just loved telling me how racist he was, and he liked talking about, you know, the different colored like skin tones, and I just found it really unnecessary. And to be honest with you, it angered me. And so I spent most of my time with him trying to address the racism, you know, when he was there for substance use disorder. So I wasn't regarding him positively. And that may seem kind of confusing to some person. Like, well, of course, why wouldn't you want to address that? Like my job was to address, like if he was saying inappropriate words in front of me, like using racial slurs or talking about that in like groups in like public places. Yes, it's my job. Hey, you cannot talk like that here. But I was trying to change his ideological state. Like I was trying to make him not be racist, and we just butted heads with each other. And then when I think about it, in hindsight, like I only have 30 days with these people. Am I going to like make a racist not a racist in 30 days? No. But that
Yeah.
was my focus, and I missed the boat and I damaged the therapeutic relationship because I wasn't focused on his drinking, which is what he was there for. So that's an example about how when we don't regard somebody positively, even if the things that they're doing is so offensive, you know, they're going to tell you stories about what they did to their spouse, and they're going to tell you stories about their past and what they did or didn't do to their children. And it's going to boil your blood,
Yeah.
especially if you have a personal resonance with those things. But you're going to have to learn to put that stuff to the side and know when it's appropriate to address. So
Uh,
we'll get into some stuff next module. Next module is a banger. You know, it's probably going to be the most. I think it's the most boring, but I was building the
yeah.
module today. There's so much good information in there that is so important, and it's all about ethics and appropriateness and when to mandate when it's appropriate to mandate to call in a mandated
Mr.
report.
Oh.
I hear you, Kashima. I'm just trying to get my thoughts out because if I
Oh,
stop,
I'm
I'm
sorry. I'm
gonna, no,
sorry.
it's okay. I got you. Um, so yeah, so UPR is foundational because our job as a clinician, especially in a substance use clinician, is to treat them for their substance use disorder, not to change who they are, not to put my beliefs on them, not to get them to believe what I believe or ascribe. And we have to like always align with this positive approach, you know. So some four kind of like tenets of UPR are non-judgment. So the counselor accepts the client as they are without evaluating their worth based on behaviors, because if we evaluate everybody based on their behaviors and substance use disorder, it's going to be really easy for us to look at our clients unfavorably, because a lot of the behaviors in addiction are not kind. They're not good. They're not socially acceptable or moral, you know. And even for those of us that are in personal recovery, it's kind of, I don't want to say it's easy, but it's a dangerous place to get into a place of self-righteousness where I may not say it, but I'm like, well, I've been sober. I've been doing this a long time. Look at you. And I may not be saying that, but I'm thinking that. And so it's preventing me from treating the client
Yeah, I
ethically and
found
effectively.
myself doing that,
So hold
wandering in
on,
my
Chaga, let
head.
me get Kashima first and then I'll get you to it. Go ahead,
Oh,
Kashima.
yes.
I was just, can you hear me?
I can.
Okay, I was wondering if what you were talking about, because I'm kind of confused about the counter transference. Is 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 that what you were talking about with the guy when you were trying to the racist guy?
I would say yes. So transference and counter transference basically are me putting my stuff on the client or the client putting their stuff on me. So I would say yes. I have a belief that racism is wrong and it doesn't make sense to me and people shouldn't be that way, but not everybody thinks that way. And I have to accept that as a clinician, especially when these people are my clients. So yes, absolutely. That would
Okay,
be a really good example of that.
okay,
I always
thank
get the
you.
two confused. I have to look it up real quick. I
So
always get the two
can I
confused.
give you a quick example
Yeah, come on.
of my thinking?
Yeah.
Okay, so somebody was sharing about like it was for like planning, like what you were gonna do like after you got out of detox. And she was talking about like so she wanted to get her kids back and like she didn't have custody of her kids. She wanted to get her kids back and then get pregnant and have more kids. So in my head I'm thinking and I didn't interrupt her, like wait a minute, you don't have your kids, but you want to plan on having more kids, like, you know,
Right.
like
What are you
hit,
doing?
hit the brakes, like, but I didn't say anything because in my head I thought if you say something like this is a really like this could really trigger somebody, like talking about getting someone's kids back, and then
Now, were you worried
that
about
could
it
like break
triggering somebody else in the group,
that
like a
could break
client?
someone down, you know.
Were you worried about her disclosures triggering somebody in the group?
No, like triggering her too, like and triggering the whole group, like talking about somebody getting their kids back and having more kids, like that would just be a trigger.
Sure. So that's a really good example that we can speak on for a second is there are ways like if the inappropriate way to address that would be to like, oh my gosh, like why are you thinking that way? That's crazy. Like that's insane that you would think that way. That's a judgment. We've placed a judgment on a client. Now, granted, we're going to have judgments, but we can't externally place that on a client because what that does is it shuts a client down and it feels invalidated. It kind of creates a power. It encourages inappropriate power dynamics where they're like, oh, my counselor is like super judgmental. I can't tell them anything. So if you want to address the thinking, because I would agree there's probably some blind spots around that. Like, why would you do this based on where you're at? With limited resources and kind of so what you would do is that's a perfect example to use motivational interviewing. So instead of
Yeah,
placing
yeah.
a judgment on them, you inquire. Well, so you've told me recently that you had a previous experience with this and it didn't work out. Now you're telling me you want to do something when you're not prepared for it. Can you tell me, does that make sense to you? Or
Yeah.
so it's a skill. So it's not that you can't address it, but you have to be really kind of creative and sneaky about it, which is where that's the thing I love so much about this job is we all come into it like with the way we are. And then a lot of the way we are sometimes can be, it doesn't fit in counseling. Like for me, like I used to be very confrontational and very like advicey and stuff like that. And I learned pretty quickly, I'm like, this doesn't work. Like I can't just tell people what they can and can't do because lose I lose their trust. So I had to
Yeah.
kind of reprogram a lot of myself, but it's very fun. It's very fun and it's kind of like a puzzle. So you'll just get good at asking questions. And I've said this before a couple times, but probably the one of the most valuable skills that you will develop is learning how to ask the right questions that guide them through the conversation where they're still giving you information, but you're not shutting them down and you're not being judgmental and you're not, kind of letting your biases show through. It can be
So
hard. Sometimes you're going to be like, I don't know what question to ask. Sometimes they're going to give you a justification and you're going to be like, I don't know what to do with that. But you
I
will develop the skill and it's very, very fun.
I'm doing a lot of self-talk. Like when things like that come up, I'm doing a lot of self-talk.
So your skill also to develop is you're really going to want to, like, if you find yourself getting lost in thoughts, kind of come back to active listening and, work on some maybe mindfulness techniques or do whatever you can to make sure that when you're listening to somebody, you're not waiting to respond. You're truly, so that means making I mean, I don't know, I don't want to get into like active listening, but that's going to be one of your dragons to slay, is make sure that you are building the skill of active listening, which is hard to do. Especially if like they say something that triggers you and you start judging them and you're like, oh my gosh, that's crazy. Like, why would you do that? Blah, blah, blah. So anyways,
Not judging them, but like when something like
not
that
externally
happens.
judging them, because you're going to judge them
Yeah.
internally. Yeah, it's impossible. Like, I don't want to set us up
But
for
like
failure
my
saying,
mind like snaps, and like that would be, something for individual therapy, like not to address in front of the group, or like, so
sure.
my
I mean,
mind's
or
always
maybe,
like,
I don't know, maybe you would address it in front of the group. Like, it's very nuanced and situational. Um, so yeah, so aspects of unconditional positive regard are non-judgment, empathy. So the counselor shows empathy, even if you don't feel empathy, like how can you show it? Respect, of course, you want to treat clients respectfully, and this word autonomy is going to come up this module and next module. It's, you want to respect their autonomy. So even if you disagree with what they're saying, instead of shutting them down, you want them to feel like they can still express their own original thinking, and they don't have to think like you. Like, no, you shouldn't say that. You shouldn't think that way. That's a bad way of thinking about it. You've just killed their autonomy. You want to let them disclose their crazy idea and then lead them away from it with some kind of counseling technique, such as motivational interviewing. And then you want to support them. You want to provide them consistent emotional support. I was reading this video the other day from this psychotherapist that says, the two things that either build or damage relationships, even outside of, like, she wasn't even talking about counseling, is trust and competence. If you can exhibit trust and competence to your client, regardless of everything else, regardless of like what you want them to do, that will build rapport like really, really quickly. So trust, meaning UPR, like, can I demonstrate these things? Non-judgment, empathy, respect, support. Can I create a safe space for them? And do I exhibit competence? Like, can they look at me and be like, you know what, Kashima, Sandra, I like them because I know they know what they're talking about. So just some things to think about. So I'm not going to go more into UPR, but this is a really good document that kind of you can save and keep in your arsenal to just build the skill on. And even number 8 right here, Chandra, it's stay present and non-directive. So avoid directing or controlling the conversation too much. Focus on being present with the client, which it sounds like what your supervisor was doing. Instead of like shutting him down, she was just letting them tell him her plans. You know what I mean? Uh, So I do want to talk about some quick challenges with implementing unconditional positive regard. For example, the example that I talked about, when you have somebody, like, you're going to treat somebody that has that situation. Like, let's say you're somebody that you've been cheated on a lot by your spouse, and maybe you've had a couple failed marriages or relationships because of infidelity. And then you have that one person that's the opposite sex. Man, I've been cheating on my girl. I've been cheating on my husband, man. And they're just telling you their story, but you're boiling and you're thinking, this is a terrible person and I hate him and I don't want to work with him. That is getting out of unconditional positive regard. Much easier said than done. So, this is the first one. You can still see my screen, right, Sandra?
yeah.
So this is the one that I struggle with the most, is when you have clients that come back multiple times
Oh,
and
yeah.
just keep relapsing. Like, I got a text message this morning that one of my first clients is back in detox again. I mean, and this dude, when I met him, was on death's doorknob, and he's been doing so great. And I'm just thinking, oh my God, what are you doing? So that would be something that if I ever treated it again, I would have to kind of put that on the shelf. Difficult behaviors, especially clients that are like borderline personality. You're going to treat clients that have difficult behaviors, uncooperative, hostile, disrespectful, mean, aggressive, resistant, all that kind of stuff. Just know that those things can, still UPR. And then balancing UPR with boundaries. So the other side of it, let's say you're really good at UPR, but you don't want to create this like, hey, I'm your bro, I'm your friend, like I'm your whatever, because that can also have its whole slew of problems. which I'll tell you a couple stories about that next week regarding ethics. So there's that document, that's UPR, so go ahead and save that. And then starting next week, we'll just kind of briefly go over some of those other counseling techniques, and we can hear from y'all. Anybody want to share anything so far? Anybody want to tell a story or comment on anything you've read?
No, but I had a question,
Go for
Glenn. I think it's module 3.
Mhm.
Is it it says tip 42 on it?
I think it's tip 42, but I typoed it and I put tip 24.
Oh, okay. Well, I didn't even notice that. But in any case, so we have another like homework assignment in the discussion board.
Or module 3?
Yes.
No, there's just the one discussion board.
Okay, because I was so confused.
What did I do?
Okay, well, it's so, all right. So it said, I think it's gone now, but it did say essay due October 6th.
Mhm.
It made it look like there was going to be 2.
I mean, that might have been something that I just was confusing. I think my intent on that was just to remind you, like, hey, the first essay is due on the 6th. And then I put a rubric up there because I noticed, so I created a rubric for the essay, which I noticed, Chong, I think I've already graded yours.
Okay.
It's kind of harder to access the rubric. Like even me, like I created a rubric for the essay, so you kind of know like how I'm going to grade it. And like I grade it very regimented. Like I follow those competent, novice, proficient things. Like I run it through a system, I read it and I run it through a system and then I double check my work. So it really looks at the details of the essay and it really kind of like picks them apart and stuff. So I put the rubric on there so y'all know kind of like how I'm going to grade. But I noticed that the rubric wasn't really easy to find in the essays. Like on the discussion boards, you just click and it says see rubric and you can see it. But for me, the rubric like wasn't as clear. So I reposted it again in multiple places just so y'all could see it visibly. So I think that's what you're probably referring to is the SA1 rubric. But it's the same thing. It's just how I'm going to grade. Does that make sense?
Okay, so and then in this module 3, so it's got another breakdown of like questions on, so it looks like there's another discussion board you want written up.
So are you in the module 3 folder?
No, I can go in there.
Well, where are you seeing what are you looking
Hold
at
on,
specifically?
let me go on course content. Okay, so all right, here we go. Module 3. Okay. Oh yeah, here we go. Module 3 PowerPoint. Okay, there. Okay, it says essay due. Yeah, so I was like wondering.
No, it's just a reminder, just the same essay.
Okay, so I already did mine. Okay.
Yep, you're good.
Thank
You're
goodness.
good. All right. So I actually don't remember. Y'all remember the slide that we left off? I do not actually.
Oh gosh.
I know we got through sequential, parallel. Oh shit, what'd I do? I broke it.
I'm sorry, I'm reading your thing on my essay.
And so you have 2 submissions. So if you want to use my feedback, because I gave you pretty specific feedback and you want to submit it again.
Oh, I had 2 submissions because I had misspellings on one of them.
Oh,
And
well,
I
I
know you
graded your
hate that.
well, I graded your second one.
Good. Because
Okay,
that's
good.
the one that was corrected.
All right. Cool. Okay, we got through levels of care. Did we get to IOP? Good Lord, I can't remember.
IOP, SOP?
Yeah, I know we started talking about it. Oh yeah, we did.
I
Yeah,
thought
we got
you
through hospital. I
Yeah.
remember. Cool. All right, so the last bit of the PowerPoint, y'all can still see my screen, right? Because it just moved. I never know what the hell's going on. So, So cognitive behavioral therapy. So essentially it's a principle based on the idea that thoughts, feelings, behaviors, typically represented like a triangle, are interconnected. So there's a lot of specific techniques, which we may get into later, but this isn't really a class on counseling theories, but I just want y'all to understand or be able to like just know what it is, because there are oftentimes like while I'll be doing group and we do this thing in our curriculum called the ABCs of resilience, which is a CBT exercise. And so I'll say, um, when I'm doing the group and I'll be like, hey guys, this is an exercise in cognitive behavioral therapy. And then somebody will typically raise their hand and be like, what is cognitive behavioral therapy? Because I forget that sometimes people I'm treating, this is their first time in treatment. So just being able to understand like why you're doing this and kind of explain it in a really like simple, concise way is important. So just know like the principle behind it is that thoughts, feelings, and behaviors are interconnected, and CBT interventions usually focus on one kind of point of those triangles and change something. So whether it's thoughts, somebody has some negative thoughts, CBT techniques will focus on those negative thoughts and either reframe them, change them, rewrite them, think about them differently. Um, and the same thing with feelings and behaviors. I love talking about behavior because sometimes clients will be so lost in the mess that changing their thoughts and feelings almost seems like impossible. It's like, man, I've been stuck in so much self-doubt and negativity that I hear you're telling me to do gratitude lists and reframing, but like it just doesn't make sense. So like I'll give you a good example. So I have this young guy in my group and I love him to death, man. He's so he's just a cool kid, but he doesn't realize it. He doesn't see himself the way the group sees him, and everybody in the group loves him, and he's kind of an underdog, and but he's just very down on himself. And so I gave him a specific treatment plan exercise, which is called the 10 and 10. So it's very simple. You just write 10 negative statements, which for most of us is pretty easy to do. Like, I hate myself, my life sucks, I'm never going to feel okay, I'm never going to be sober, whatever. And then you flip them and you rewrite them with 10 positive statements. So the example I always give is, let's say your first negative statement is, my life sucks. So you rewrite it with something like, my life isn't where I want it to be, but I can begin to do things today and make small changes to move myself in a different direction. So even if you don't believe that positive statement, the rewriting allows a person to kind of practice mental rehearsal and get into the state and put themselves in the emotion of something that hasn't happened yet. And so it's kind of like it's like the fake it till you make it principle, but with some meat behind it. You know, like I don't believe in just saying fake it till you make it, because some people will do that and they don't really understand like what they're supposed to do with that. Like, okay, I've been faking it for so long, but if you believe a lot of the data, the research says that, you know, mental rehearsal can be very powerful. So if you rehearse something, even if you've never experienced it, your brain and body can experience the sensations, the emotions of a future event. And we all know that's true, because have you ever sat down and thought about something negative and all of a sudden you're feeling anxious and in a panic attack? So we can create experiences based on thoughts. So if we can create negative experiences based on thoughts, why can't we do the same for positive? And the truth of the matter is we can, but it takes practice. So I say all that to say, so I gave him the assignment and he came in to process it. And he was like, I was like, hey man, you ready to process? And he was like, no, I don't have anything to process. And I was like, why? And he's like, I don't know. I started to write it and I was like, I didn't agree with it. You know, it just didn't make sense. So I didn't do it. And I was like, okay, well, why didn't you agree with it? He's like, I started writing positive statements, but I just didn't feel like I feel like I was being fake and I was just making stuff up. And so we had to guide him. And actually the group really helped me too. And guiding him and understanding like, that's okay. The fact that you don't believe it, you're still going through the motions and putting yourself, and it takes practice. So these can be very powerful, tools, but we gotta give them to the clients. So there's a whole books on CBT. It's probably the most widely. I mean, I don't know this for a fact. Like I can't substantiate this with any kind of data, but I know CBT is very effective. It's been around for a little bit. It's what a lot of people use. So if you're
No,
not familiar,
I totally believe that. I
yeah,
totally agree with that. It was kind of like me with staying sober. They told me to pray, but I didn't believe that was going to work. And now,
right. And look at you now.
yeah,
So applications
Now,
of
now that's a
CBT,
given. I can't live without it. So
right. So applications of CBD in SUD treatment can look like recognition of triggers, coping strategies, cognitive restructuring, which I mentioned, which means challenging negative thoughts, behavioral activation. Oh, and I forgot, I totally lost my train of thought, but I love focusing on behavior because even if a person doesn't believe that they can do something, just tell them to do the behavior anyway. And if they stick with a behavior long enough, there will be something that changes as a result. So somebody in treatment that's told to make their bed every day and they're like, why am I going to make my bed? This doesn't make any sense. Like, I'm here for heroin and anxiety. Like, why am I going to make my bed? But what you're doing is you're engaging in behavior. So you're putting your body in doing something that it's never done, and you build the consistency, and all of a sudden you turn into a person that has a consistent habit of making their bed. And it's a small change, but a lot of times it can kind of create that fire of motivation where they'll start to appreciate it. And now they come home and they have a clean bed, and it makes them feel good about things, even in a really subtle way at first. And it just kind of compounds and snowballs. And it can turn into what's known as a keystone habit, which is like once you kind of
yeah,
get the first habit down, it has like a trickle down effect. For instance,
I
somebody
want to
that
see my bed's made.
yeah, exactly. It's a feel good thing, you know, and
Yeah,
but
that's
there's meat
that's
behind it.
where
It's
it
not just something
starts.
we yeah, it's not just something we tell people to do just to do it. Like there's substance behind
Oh my
it.
gosh, yes.
So CBT, now dialectical behavior, I'm less familiar with this, but I dig it from a personal standpoint because I've heard a lot of presentations on it. And it's basically cognitive behavioral therapy with a little bit of mindfulness. So uh, mindfulness principles such as like getting in touch with the present moment. It talks about things such as non-judgmental stance, which is like in meditative practices, if a person is trying to get familiar with themselves and they're into meditation, then they sit down and they sit with their thoughts, but they practice not judging them. So if they have like a crazy thought, usually there's a judgment that follows, like, oh man, I shouldn't think this way, or that's a crazy thought. Well, non-judgmental stance in JS is just building the practice of sitting with that thought, trying to move away from judgments and just letting things be. So the four core skills of DBT are mindfulness, distress tolerance, emotional regulation, and interpersonal effectiveness. They can help clients handle cravings, improve emotional stability, and develop healthier relationships. I will say this, regardless of, because I know different people are going to go work for different institutions, and certain places may really kind of dictate what you can and cannot teach the clients. Like I know when I went to the park back in 2006, my counselor had to talk about only what the park wanted him to talk about, which I get it, like kind of like stay in the lines of the curriculum, but he was a kind of a creative thinker, and he kind of thought outside the box, and he would get in trouble. I say all that to say, like, regardless of what your institution wants you to talk about or makes you like teach the clients, please develop a really robust program or curriculum or lesson kind of like series around emotional regulation. So important, so powerful. Like not just coping skills, but how to regulate emotions, how to calm limbic responses, how to understand, you know, how much their perception and their behavior changes when they get into these swing emotions, you know. So it's not about not feeling the emotions, it's about being really mindful and understanding at a really basic and deep level that emotional regulation is, that's like the promised land. If you can regulate emotions, man, you're free. So if you have somebody that likes to fight or is really aggressive and really wants to get into some kind of peace, but can't get on I-10 without like losing their shit and like road raging at people, and then getting into like, and like that road rage turns into a bad mood, which ends up affecting their stress level at work, and they end up taking it out on their family at home. Like that's not an effective way to live through life. So I really believe, like I spend like sometimes 2 weeks just talking about emotional regulation
So
with my
would
go ahead.
that be DBT for the emotional regulation? Like, what would be the most effective treatments for that? Because do you know how many people I know that like they're like ragers like that. Like
Mhm.
they'll just go from 0 to 60, like
Yeah.
at the drop of a dime.
Yeah, I'm one of them. I mean, I'm not, I can honestly say like
Well,
I'm not
somebody
since I
very
got
close,
sober. But
somebody
man, when
very
I
close
was
to
in
me
my
is.
addiction, yeah,
Yeah,
I was a
somebody
rager.
very
And
close to me is.
it's not a rager. It's a person that gets dysregulated very easily. Like
Yeah,
the
yeah.
word dysregulation is my
Okay.
favorite. It's one of my favorite words because it really kind of encapsulates it from a biological standpoint and from a like a nervous system standpoint, like what happens when a person gets dysregulated, when they flip their lid,
Yep.
whenever their prefrontal cortex gets turned off, when fight or flight takes over. Like we are not effective people. Like if we're trying to protect our family, a dysregulated state is very helpful. Like dysregulated meaning
Yeah.
fight or flight, where my blood gets kind of diverted to bigger muscle groups, so
Oh,
I
yeah,
can
it
be
would
more.
be really helpful, but
Yeah. But if I'm dysregulated sitting next to my coworker that's chewing really loud and I just don't like them and I end up losing, like that's inappropriate dysregulation. You know, if I'm
yeah,
just sitting there just, oh my gosh, I can't stand this. And, or my kids are running around and I've had a really stressful day and then I blow up, like that's not good dysregulation. You know, and a lot of
so
people
like,
may justify it. Well, like it's really stressful, but I always like to think about these things from a very selfish standpoint, because when a person, and they've looked at this in specifically the neuroscience community, the psychological community, when a person is dysregulated over long periods of time, it creates a lot of problems later down in
yeah,
life. Blood pressure, disease, um, maladaptive behavior. No machine or organism is supposed to live in stress constantly. You're supposed to get into stress, supposed to get dysregulated. You're supposed to get out of dysregulated. I'm dysregulated because I got to do something. I got to move. I got to fight. I got to attack. And then I come down, you know, and you see a lot of animals. That's how a lot of animals live. If you ever see like a deer or like a duck, like ducks, like when they fight on the water, they'll kind of go towards each other and then they'll squawk
yeah.
around for a little bit and then they'll turn away and then they'll kind of shake it out, like dispel the negative energy, and they go on throughout their day. But we as humans, because we're much more complex, we don't do that. I'm still replaying that argument I got into with my coworker 2 weeks ago, and I can dysregulate myself in the present moment by just thought alone. That's not effective, you know, because it's kind of like what you were talking about earlier, Chandra. Like that's where the racing thoughts, like I'm sitting there and I'm supposed to be paying attention in group, but I'm just ruminating on this freaking conversation I had 2 weeks ago. And I don't know why I can't get it out of my head and I can't think it about it. I keep thinking about it. So anyways, I got you, Kashima, I mean, many of you are probably already very familiar with this because I know a lot of you have worked in the field and are professionals and have some experience in recovery, but like do a lot of professional and personal development on understanding emotional regulation and how to teach that. So important. So important. Everything from understanding what the negativity bias is, understanding what flipping your lid means, understanding what the difference between sympathetic and parasympathetic nervous system responses. Um, I highly encourage you to do that. Super important. Kashima, yes, ma'am.
So is okay. So dialectic behavior therapy is about emotional regulation and you said something you're talking about, but so it's about emotional regulation.
It can encompass that. And CBT can be about emotional regulation too. The way I like to describe DBT, and this may not be like the best way, but DBT is CBT with mindfulness kind of sprinkled on top of it. And so mindfulness is basically like awareness, being in touch with like yourself in the present moment, acceptance, like I said, like non-judgmental stance, meditative practices, some spiritual concepts too. Um, yeah, just kind of like grounding in the present moment. So now I'm
Okay.
talking about it too much, and I'm wondering if that's an accurate definition. Let me look up the definition of mindfulness. Yeah, so mindfulness is the practice of paying intentional, focused attention to the present moment without judgment. It involves being fully aware of your thoughts, not being scared of your thoughts, being aware of your feelings, bodily sensations, and surroundings, and accepting them as they are, rather than reacting to them or becoming overwhelmed by them. Mindfulness is often used as a tool for stress reduction, emotional regulation, and improving overall mental well-being. So CBT will have, because like emotional regulation, like if you think about the triangle I mentioned earlier with CBT, is emotional regulation can come from all three kind of points of that triangle. Like I can have a thought that can dysregulate me, I can have a feeling that can dysregulate me, and I can have a behavior that can dysregulate me. So both of those techniques can be used to teach and address emotional regulation. But good question though. So here's that motivational interviewing. So this is going to come up a few times. I know we talked about it before, and many of you may already be familiar with it. But it's a client-centered approach. Very, very important. Client-centered, also very closely tied to unconditional positive regard, where it's an approach that enhances intrinsic motivation to change by exploring and resolving ambivalence. So it's rooted in empathy, partnership, and respect for the client's autonomy, not hardcore compliance and you got to do it this way and stuff like that. This is me really trying to get curious and using skillful questions to encourage the conversation going forward. Even if like I'm basically trying to tell a client, that's crazy. Why the hell would you do that? How can I take that and turn it into a question? So you told me that, so I'll give you an example. So I had a client that was drinking, I think I even shared this with you. I had a client that was drinking pretty much all throughout IOP. And some of the things, and this is where like the active listening comes in. A lot of the things that this client shared with us is this client got divorced because of the drinking. This client's children were she was estranged from her children because of the drinking. So she had all this like evidence about why drinking no longer is working for her, but she continued to drink in IOP. So every time I would address one of the relapses, I'm like, you're drinking while in IOP. Like, what's going on with that? Well, I'm making progress. I'm not drinking as much as I was. Like, I'm spending more time with my kids. And so we would go back and forth for a while. And then finally I was like, listen, you have shared with us these things. And you're continuing to do that one thing that created these things. Can you tell me how that makes sense in your head? And I got a response that was like, well, I'm making more progress or I'm doing better. And I said, I know you feel like you're doing better, but do you really feel like you're doing better based on what I just said? And to be honest with you, like I couldn't really get anywhere with this person because this person actually believed they were doing better and they absolutely weren't. But instead of me telling them, using questions to encourage them to kind of come up with their own conclusion. And I really believe this person wasn't able to come up with their own conclusion because they were under the influence. You know, there's a lot of irrationality whenever a person is under the influence. So motivational interviewing is used in SUD treatment to help clients identify their own motivations for change. These techniques include reflective listening, asking open-ended questions, and summarizing to help clients articulate their reasonings for wanting to stop using substances and build confidence in their ability to change. So this slide is evaluating the appropriateness of different treatment approaches based on client needs and characteristics. Such things as client-centered evaluations. This involves assessing clients' individual characteristics, including severity, co-occurring disorders, stage of change. We've kind of talked about that. This is more just focusing on pay attention to the client and create a treatment approach that is not just handing them generic worksheets, but like, what do you want to work on? What do I think you want to work on? And really being curious about what's going on with them. Now we're going to move on to evidence-based practices, EBPs, in the context of sub-treatment. So essentially, EBPs refer to treatment approaches and interventions that have been scientifically researched and proven through effective, rigorous evaluations. So an example of an EBP would be cognitive behavioral therapy. It would be I'm drawing a blank. CBT, DBT, narrative therapy. Oh gosh, I'm drawing a total blank. But like pretty much everything that you're going to use that's already kind of established, whether it's in the curriculum of the organization that you work in, or another example of an EBP would be like the HIMSS program with pilots, the Human Intervention Management System. Let me look that up. The HIMSS program is what pilots get put on when they self-report or they get caught like drinking or using under the jobs, and they have to go into like this monitoring program. So it stands for Human Intervention Motivation Study. I apologize. So that would be an evidence practice, and they even have very specific statistics around the success rate of pilots that engage in this very rigorous program over the course of time. So that would be another example of evidence-based practices. So all you need to know is pretty much the point of this is saying like, I don't want to get there. Like, let's say I have a lot of beliefs around the world. Let's say I'm very conspiratorial in the way I think. Like I feel like there's aliens and Mark Zuckerberg's a lizard person. And so I get there and I try to teach clients based on that framework. Like, listen, guys, the government's out to get us and there's lizard people. That's not an evidence-based approach. I want to kind of put my stuff aside and make sure that I'm teaching them things that are grounded in data and they're empirical and they've been proven and they're established, and not just the world according to Glenn, because I have some pretty crazy ideas. So characteristics of what makes an EBP kind of like an EBP. So it's research backed, it's replicable, meaning it can be implemented in various settings. So like it's something that can be taught in residential and individual therapy, whatever. It's client centered. So it's considering the individual unique characteristics of the clients, such as cultural, personal preferences, and level of motivation. Also stage of change. It has measured outcomes. So the success of an EBP is measured through observable and trackable client improvements, such as length of sobriety, fewer relapses, improved mental health, so on and so forth. And they're ethical, like even if it's, let's say you have well, this is kind of a stupid example, but like, let's say there's an evidence-based approach that involves kidnapping clients, putting them in a van, putting them on a desert island and depriving them of all food and shelter and being like, you know what, you got to stay here for 2 years. And if you can survive, obviously, and stay sober, then that's not ethical. You know what I mean? That's kind of a stupid, crazy example, but so most widely accepted evidence-based, I'm just going to say EBPs going on from this point forward, evidence-based. Oh, what's happening? Evidence-based practices, cognitive behavioral therapy. Why it's evidence-based? Because it's been proven effective in reducing relapse rates and promoting long-term recovery, especially when combined with other therapies. Application in SUD, substance use disorder treatment, focuses on identifying triggers for substance use and developing healthier coping strategies. Motivational interviewing, studies show that motivational interviewing significantly improves treatment retention and outcomes by increasing clients' readiness to change. Because I've created a safe space, I'm using this to build rapport. The clients feel like one of our biggest tools, what I said at the beginning, which was if a clients know they can trust you and they know you're competent, and you can combine that with really effective motivational interviewing, and they believe that you're here to help them, oh man, you've won. Even if, the nothing else seems to be like, just, it's so important in establishing the therapeutic alliance. DBT, also another EBP, evidence-based practice. Research supports its efficacy, so its effectiveness in reducing substance use and helping clients manage cravings in high-risk situations. I'm going to add like my opinion in this. So DBT was originally designed for people with borderline personality disorder, but even though I'm not as familiar with DBT, like I do a lot of mindfulness stuff in like my own personal work, and it creates a lot of new awareness around a person's self. And when a person starts to really kind of understand themselves at a deeper level, and they can kind of make sense of things. Whereas before I'm like, I don't know why I'm this way and I don't know why I do this and why things are this, like a lot of question marks. When a person can start to kind of get a deeper understanding of themselves, and mindfulness and DBT can do that, then they're more likely to stay. It's like, you know what, I kind of understand why I think this way, and I understand why I have these emotional reactions, and I understand why I'm in fear all the time. I understand why I'm insecure. And it can be a really, really awesome experience for when a person can step into that.
Where your juice that was up in the car?
Kashima, can you mute your microphone?
Oh, sorry.
It's okay. So, oh, what happened? There we go. Contingency management. So I've never seen this in practice. Well, I mean, I have, but like just loosely. It's basically just using positive reinforcement. Pizza parties, candy, shit like that. Like, hey, if you stay sober if you do all your treatment plan, we'll have a movie night, just kind of positive reinforcement. So clients are rewarded for meeting specific goals. Kind of self-explanatory. 12-step facilitation therapy. So guiding clients through the 12 steps, that's all I'm gonna say about that. And I love 12 steps, by the way. Like that's kind of like my personal thing, but I don't know a lot about the data and the statistics behind it. Matt. So most used and widely accepted evidence-based practices, you're going to come across Matt. I know many of you already have. This is going to be one of those things where a lot of people, you're going to have to put your personal biases aside, especially if you ascribe to, well, I don't think people are actually sober if they're taking 16 milligrams of Suboxone. Because I've seen clients that are on 16 milligrams of Suboxone and they're nodding out in group and they're not coherent and they're slurring and they just seem high, so but regardless of how I feel about it, these are appropriate and effective interventions that are at our disposal. So if I have a bias that I'm treating somebody that has an opioid use disorder and I just don't like people being on Suboxone and I don't volunteer that to the client when they may not even know that's available to them, I am ethically doing them a disservice. So medicated assisted treatment, which would be methadone, buprenorphine, naltrexone. I mean, I'll give you a perfect example, like methadone. Like methadone has been shown long-term to do horrible damage to a person's internal systems. But that's, if it gets a person off shooting heroin every day, then who am I to not allow a person to try that intervention? And whatever they do with that is that. So most commonly used for opioid and alcohol use disorders. Yeah. Numerous studies show that MAT is one of the most effective interventions for opioid use disorder, improving retention and treatment and reducing overdose deaths. I agree with this because I've seen it. Even though I have some certain feelings towards certain MAT, like I've seen it work. Like I cannot deny the potential efficacy it has in somebody that's like, you know what, I haven't been able to get 30 days sober, but then I finally got on 4 milligrams of Suboxone or Subutex or whatever, and I'm good. So awesome. Use all the tools at our disposal.
Um,
Yes, ma'am.
I don't even know what the guidelines are for that second essay because I was gonna write that tonight. But I was gonna write it about naltrexone.
So let me develop a rubric for it over the next couple weeks so you can know what the guidelines are. Does that make sense?
Yeah, I gotta look and I gotta look and see what it wants us to write about. I think
Well,
we could
it's
take
you have a lot of options, and I've been thinking about this a little bit. I don't know if I'm going to do it yet, so don't take this with a grain of salt. Like I'm thinking about either maybe changing the essay or giving you like another option because I really feel like I want to give y'all something that allows more kind of research, exploratory kind of things, rather than just kind of like free write and stuff. So like essentially what I'm trying to say is I'm debating whether or not I want to put y'all to more work, like some more like, serious work. I don't know yet. I haven't really, it depends on the midterm and this and that.
I already did all my research.
I know. So just, I'm not going to take it away. Like you can still have that option to explore it. But yeah, just,
I mean, it's going to be a positive. It's not going to be negative.
I mean, even if it's negative, that'd be okay.
Well, it wouldn't be negative, but okay. All right.
So Matt interventions available for opioids. You've got methadone, buprenorphine, naltrexone, Vivitrol. You can either get this in a pill or a shot. Lofexidine, I've never heard of that before. Probuphine and Sublocade. So the reason why I put naltrexone either pill or shot, because this is where you can get creative. And I actually learned this from clients. So naltrexone, it's an IM, it's an intramuscular shot in the behind that lasts for 30 days. So meaning if a person has a choice, like, hey, like, do you want to get on Vivitrol? What's Vivitrol? Well, it's this drug that kind of gets in the way of, the opioid receptors. So if you were to relapse, like you don't get high, and it could kind of serve as a placebo effect to help you manage some cravings. Well, what is it? Well, it's a shot or a pill. I don't want to do the shot. I want to take a pill. What do you think could be? Now, granted, they have every right to choose which route of administration they want to do, but what could you see be the problem with pills?
Oh, with pills?
Yeah,
Well, they could stop taking it
they could stop taking them.
and
Yeah.
and then just start using opiates
Exactly.
again.
Exactly. So that would be a way that you can kind of encourage them and kind of present them with the information like, hey, like typically, like, why don't you just do the shot? Because, it's kind of a decision. It's a one-time thing. You can make it. If it's a pill, you could, forget to take a dose or miss a dose or forget to take it, whatever. So there's a little bit more, I don't want to say risk, but you have to be more responsible for that. And if this client's not responsible, maybe that's not the route they want to go.
I think the problem with the shot is people don't want to commit to that. Like they don't want to commit to actually staying sober. They're like, well, what if
That's a
I
good
want
point.
to use within the
That's a
30
great
days?
point. I
It
agree with
is
that.
because that's why I was so chicken to get it.
So that would
I'm
be
like,
a way
oh,
for
that's a big commitment. 30
Kashima and
days.
Chandra, if you feel like a client's balking, like, hey, you said you wanted to get Vivitrol, and now you're kind of seeing a little like, what's up? Man, I just don't know, man. I don't think I need it. You know what? Let me ask you a question. Are you worried about once you make the decision that for 30 days you can't get high? Yeah, you're right. You
Absolutely.
got me. You know what I mean? So you can be really curious about it. So yeah, that's a really great point.
Oh, they don't want to admit it, but I'm telling you, that was my reasoning.
Well,
When,
and the
when
other
I
part of it
finally
too
got
is,
it, that was the best decision of my life. But I'm just saying, like,
and you can tell them that would be an appropriate use of self-disclosure where you could be
yeah,
like, I did this and it worked for me, and they will listen to you. I know a big thing with the Vivitrol shot is I know a lot of sometimes men, because they have to go to our residential facility and get it administered by a nurse, which means they got to go into an office and drop their pants and booty cheeks are hanging out. And they're like, nah, man, I don't want to do that. Like, I don't want to, sometimes that can be a barrier, like there can be some self-consciousness or some insecurities around that. So just to be aware and kind of guide them through it appropriately. So Matt, for
see,
alcohol would
once
be,
I got it after the 30 days, I just started taking the pills, and it was fine. I kept taking them. I had no more cravings. Gone.
there you go. So alcohol, you've got antabuse, which is disulfiram, naltrexone, shot or pill, Vivitrol, and a camprosate, which is Camprol. There could be more, but those are the ones that I'm most familiar with. Yes, ma'am, Kashima.
We had my first time we had I had a client the other day that came in for our a medicated assisted treatment program, and we do buprenorphine, but my first time ever seeing somebody whose opiate was methadone. Her drug of choice was methadone. So I've never I thought methadone was used to medicated assisted treatment for opioid use disorder, but I've never seen anybody whose drug of choice was methadone.
I haven't either.
Yeah.
So that would be a good kind of like cautionary tale. It's where like I've never seen somebody. So you bring up an interesting point, Kashima. Like I have never heard somebody say this, but I have known clients, especially when I was the director at our sober living facility, they would abuse their Suboxone. And if anything, because like we would have to keep their Suboxone in the safe and it would have to be administered like at time by a staff member. And sometimes they'd come in and be like, hey, like I got to take the bus late or I got a work shift. Can I get double doses? And you tell them no, oh man, they lose their shit. It's almost like, and it's almost like, and I've even had some people that didn't get mad that were like, no, you don't understand. Like if I can't get it on the bus home, like I'm gonna start to feel weird. And they get really, really anxious and angsty about it because drugs like methadone and Suboxone, if you get it, you're gonna experience withdrawal symptoms. Which is
Yeah.
kind of like my thing for, which is like my bias that I have to be aware of is, and I got to be careful with how I talk to the clients about it because it's almost like I can seem like I'm giving medical advice, but like if I have a client that comes up to me like, hey, I've been taking 16 milligrams of Suboxone. I want to get off of it. Like, okay, let's get you hooked up with the doctor. Let's get you on a
Mhm.
titration or some kind of like taper protocol.
Mhm.
And then if they ask me, I'm be like, listen, because you asked, I just want to let you know it's probably gonna suck.
Yeah.
Like even if you get down to 2 milligrams and you taper off of it and you do it the right way, it's gonna suck for a couple days. It may not suck to the degree of like getting off heroin, but you're gonna feel it. You're gonna feel restless and a little bit of withdrawal symptoms. Everybody's different, but like I just want to prepare you for that. It's gonna suck.
Yeah.
You know?
So I found myself kind of, I don't know if I was being biased, but I started thinking too much in my head. I was like, because we serve the population with no insurance. So I thought to myself, well, darn, if you was addicted to if methadone was your drug of choice, then what would you do with the Suboxone? I thought that she was drug seeking, um, because it seemed that way. But then I have to question myself: Am I being biased, or am I putting my own thoughts into it?
I love that. I love that. That's actually a really good example of how you were able to kind of CBT yourself, cognitive behavioral therapy.
Yeah.
You kind of you challenged the way you were thinking. You kind of got out of unconditional positive regard and you came back. So that was beautiful.
Yeah.
At the end of the day, as a counselor, it's not that we can't have these thoughts because man, I talk mad shit in my head, and I judge people and I get mad and I get offended and whatever, and I have all kinds of biases, but it's externally what I do with them. That's the part that we can control. You
Yeah.
know, um, I even had we took this blue basin treatment, and I'll be honest with you, I've experienced this twice, where we took this blue basin, which is kind of like the we don't
Mhm.
use it anymore, but it's like the company that would give us all our CEUs, like
Yeah, we have to use Blue Basin too.
blue basin. So, and one of the, I think it was either the ethics or one of the really big ones, the lady, she was like, listen, you may develop feelings for your clients. Like you may find them attractive. You may develop some kind of biases. And I thought that was really interesting because I was a new counselor and I was like, damn, like she really just put it out there like that. And then sure enough, like I have 2 clients where, and to this day, nobody knows about it because I didn't need to tell anybody, like it never went anywhere. But there was one client, I was like, I'm like kind of like digging this person, I like their personality and stuff. And so being mindful of that, it was almost to the point for me because I'm so scared of like losing my license. I kind of like ran away from him. I like didn't give him as much attention because like I don't
Yeah.
want them to get the wrong idea. But it's just you got to be honest when these things happen, like biases, attractions, transference, counter transference. Like these things are going to happen. You're going to want to. All these things are going to happen, and it's okay. It's what we do with them externally.
Yeah.
And if it gets to the point to where, let's say you have a client that whether it's because attraction or it's getting inappropriate or you just don't like them because maybe they remind you of like an abusive family member. If you don't feel like you can effectively treat them, give it a chance. Like try to work through it. But if it's to the point where you just can't do it, go talk to your supervisor. Be like, hey, can we switch? I'm really letting my biases get in the way. And to be honest with you, like I've had a couple times where I have this one client that I kept treating that just drives me up the walls because it was like everything that they said was manipulation. I couldn't believe anything out of their mouth. I couldn't tell which way they were going. And it got to the point where I went to my president. I was like, can I have your permission to not interact with this client? And she was like, yeah. But we had to develop a plan, like what that looks like.
Mhm.
But just kind of being honest and owning it and then making sure that what I'm doing with it is within the grounds of appropriateness and ethics and stuff like that. So good question. Good point.
I think with me, like the other day, I had a moral dilemma. I think when
Oh, I love moral dilemmas.
yeah, we had so I come from I've been through some stuff in my life, like with trauma, like childhood, sexual abuse and stuff. So we had a participant, and I hated these people, and so we had a client come in for the IOP program, and they was registered sex offender,
Hmm.
and so when my coworkers found out what they were charged with, man, everybody was like devastated. You could tell they were changing the way they felt about the person. And so I was like, I'm a RSPS supervisor, so I was like, y'all, we can't have any judgment or bias. And then while I'm saying this, I'm realizing to myself that I didn't feel anything. So I'm thinking to myself, I stayed up all night long thinking about that, because where I once felt you know, emotions toward people with this being learning about being a clinician, is changing my whole I was like, we got to help the person that's in front of us, not the behavior. And so, and then I felt like I betrayed myself, because I come from a long line of that, not even
Hmm.
realizing that this is being a clinician, it's changing my whole perception of things. So, and I was like, am I betraying what I've been through? I stayed up all night long thinking about that.
Well, that's a really so hey, I want to commend you. It sounds like you've done the work. It sounds like you've moved into kind of some deeper acceptance. And as a clinician, you've been able to put your past experience. So you're not, because I would see the other side of it would be if you led into the counter transference where
Yeah.
you were acting like that's obviously the wrong way. That's not the ethical way.
Yeah.
But the fact that you were numb to it, I don't know. I don't know. Maybe. But I'm going to kind of like try to counsel you a little bit for the second, but like I don't know if that's a good or a bad thing. Like that's a very personal
Yeah.
decision. But the way that I think about it is, if you are numb to something that used to run your life, like if this experience and trauma and this narrative surrounding what happened to me either created like a previous victim or poors me, and you're not in that place anymore, I would say that's a good thing. I would say that
Yeah.
you've been able to step outside of that story and rise above and go from maybe a victim to a survivor, even if
Yeah.
that feels numb. And it probably feels uncomfortable because it's new. It's a new space that you've
Yeah.
stepped into before. But I mean, I don't see that as necessarily a bad thing, but ultimately it's not for me to judge, you know?
Yeah. It was very uncomfortable. Because when you get used to something, feeling a certain way your whole life, and it's anger, and then you present it with it, it's like God gave me a second chance to understand that side of the story.
Yeah,
We
no, absolutely. Absolutely. So that's what's things like that, Kashima, are what's going to make you a more effective clinician. Because there's going to be other people that have PhDs and masters that are not willing to do that, that are going to let their judgments and biases interfere. I've seen it. Like I've
Yeah.
seen it in real time where a person can't get out of themselves
Hmm.
and is always just butting heads with clients and getting defensive and
Yeah.
it just doesn't work, you know? So good on you. Do y'all want to take a break real quick? We've been kind of going for a while. You want to take a quick break?
Yeah.
Oh,
Yeah.
yeah, that'd be awesome.
Cool. Because we don't have much longer. So we'll
Okay.
break and then we'll come back and we'll get this done.
Oh, cool. All right.
Mhm.
All right.
Thanks.
See you in a bit.
Okay. Bye.
All right, ladies and no gentlemen. Oh, you know what? There are no gentlemen in this class. It's just me. That's okay. I
Just
just realized
us.
that. It's just women in this class. Because men are too scared to get into counseling. I'm just kidding. Let me stop.
No, I think we have one guy in the counseling class.
All right. All right, y'all. Let's. Oh, I'm gonna make an announcement. So next week will be in person, but because the in-person attendance it's been more people online consistently, I'm gonna alternate. I'm gonna do 1 week in person, 1 week on WebEx.
Okay.
Because just to be honest with you, it's easier for me. Like I really don't want to drive up for just one person. But I
Yeah, I don't
will.
blame you.
I'm just not gonna do it every week. Um, let me. What is happening?
I live too far to come in person. I live close by Sugarland.
Yeah. I mean, see, you
Uh,
and I live in Katy, so
oh, okay, yeah.
yeah. I love in person. I just um my workload is getting too big, and I have a PHP client now on Tuesday, so I'm pretty much doing group on Tuesdays now too. Anyways, enough about my sob story.
Oh, I hate this thing. Sorry.
You hate what?
I'm trying to download this thing, Zelle, and oh, what a pain in the butt.
Zelle? You can't use it through your
Yeah.
banking app?
Yeah, Zelle. I've never used it.
Who do you bank with?
Oh, where's my bank?
Yeah, which bank do you
Oh,
use?
oh yeah. You don't. You know what? I've heard. Oh man.
Sorry, we don't have to get into it.
I use
Because a lot of
Country.
banking apps have Zelle built into it.
No, I use Country Bank in Massachusetts. I've gotten
Okay.
enough crap about it because I
Yeah.
haven't switched to Texas yet.
You need to get some Chase in your life or something.
Yeah, I know. I've heard all about it.
So for Suboxone, I did want to focus a little bit on Suboxone briefly because understanding how Suboxone works is really, really important. Just so you can educate your clients, and also as a clinician, just can better understand what the purpose of it is, what it does, so on and so forth. So it's probably going to be the most common MAT form of MAT used for opioid use disorder. It's a combination of two drugs, which is buprenorphine and naloxone, and it fits into MAT as an effective treatment for not only reducing cravings and withdrawal symptoms, but lowering the risk of misuse. So how it works is the drug buprenorphine is what's considered a partial opioid agonist. What that means is it binds to the opioid receptors in the brain, but it activates them to a lesser degree compared to full agonists like heroin or methadone. This helps reduce cravings and withdrawal symptoms without producing an intense high associated with other opioids. Now, when a person, like especially if a person's never taken Suboxone before, first couple times they may get a little high. It's just kind of what it is. So just know if you're working at a sober living and you're doing IOP and you see Johnny starts nodding out and he got on Suboxone, obviously go through the motions and ask the questions, but just know that could happen. Now naloxone, which is an opioid antagonist, what an antagonist does is it blocks the opioid effects. So when taken as prescribed, sublingually, basically under the tongue, on the tongue, naloxone is inactive. So if Suboxone gets misused, like yes, some people inject it, naloxone becomes active and it blocks the effects of the opioids, discouraging misuse. So buprenorphine, partial opioid agonist, meaning it binds to the receptors, but it activates them to a lesser degree. And naloxone is an opioid antagonist that blocks opioid effects. All right, so trauma-informed care. This is we're going back into more evidence-based practices. So trauma-informed care, I actually just became aware of this about a couple years ago because one of my clients that I treated ended up getting a job in the field and going to work at a place that apparently they use this. And from her perspective, apparently it doesn't work. Now, that's just based on her own opinion and something like that. But the approach is it recognizes the prevalence of trauma in individuals. So you kind of treat them gently. You focuses on creating a safe, supportive environment that avoids re-traumatization. So application is it helps clients build trust and develop healthier ways of coping without relying on substances to manage trauma symptoms. Why it's evidence-based is trauma-informed approaches have shown positive outcomes and why treating co-occurring trauma and SUD. So like practically how this would work is like, let's say you're in a process group and someone is processing on their trauma and they're getting into like gory details about like a sexual assault. You would want to kind of move them away from that or make kind of like intervene, especially if you're working in a trauma-informed approach, because the intervention is designed so you don't re-traumatize other people. So in evaluating the appropriateness of different treatment approaches based on client needs, so I don't feel like I really need to go over this again, but you just want to know. So like, if you know a person, let's say you work at a place and you can use whatever approach you want. You can use CBT if you choose to, DBT. But let's say you have a person that just doesn't like the mindfulness stuff. They consider it psychobat, or they consider it kind of like woo-woo stuff, like anything that kind of sounds spiritual to them, like present moment. They're just like, you just know they're not into it. So that would not be something you'd want to use. You maybe want to use into something more like smart recovery or something that's based on more science or something like that. Oh Lord, what happened? So just really quickly, these are kind of going through like, give you an idea about where one of these might fit into a certain situation. So CBT's appropriateness is effective for individuals who struggle with substances as a result of negative thoughts, emotions, or stress. Particularly beneficial for clients who are ready to engage in self-reflection and change thought patterns. Best for clients with co-occurring mental health disorders like anxiety and depression, and those who benefit from structured, goal-oriented approaches. It is the most widely used and effective treatments for SUD, especially when combined with other interventions like MAT, and it can be effective for long-term relapse prevention. Motivational interviewing is ideal for clients who are ambivalent about change, because I don't know if I want to get sober. So you're asking questions and you're probing and kind of guiding them to, well, you said you want to be happy. You said you want these things. Do you think that you can achieve those things and still shoot heroin? No, yeah, I know I can't do that. Blah, blah, blah. So best for clients in the pre-contemplation or contemplation stages, which if you remember for the stages of change, otherwise known as the trans-theoretical model, those are the first two stages. So they typically come in pre-contemplation, and contemplation is the next stage after that. So people that are unsure or resistant, what did I do? So motivational interviewing is widely used in initial stages of treatment. It's highly effective in engaging clients who are not ready to fully commit to treatment, because it's very welcoming. It's very validating. When you're asking questions, they feel seen and heard and understood, instead of you as the clinician just telling them what they should or shouldn't do. So DBT is appropriate for clients with co-occurring disorders such as borderline personality or severe emotional dysregulation. For those that have experience with borderline personality, you will know that the emotions are very, very big. When they love you, they love you. When they hate you, they hate your guts. It's very, very big, and it can change very, very rapidly. In my opinion, this is my opinion, some of the most challenging clients to treat, especially at the residential care, because everything is, you just never know if they're coming or going. So clients that have high impulsivity, maybe they engage in a lot of compulsive behaviors, have history of self-harm, difficulties in managing emotional distress. It's also effective for people that have histories of trauma, because it allows them to reflect appropriately without fear of the reflection. So DBT is particularly effective for clients with both SUD and co-occurring mental health disorders. It focuses on building distress tolerance, emotional regulation, and making it effective for dual diagnosis treatment. Contingency management is basically just effective for, once again, I've never experienced this, so this is just what the information suggests, is Like if you know that you have a client that just won't go to group, if you give them a piece of candy in your office, like let's say you're a counselor that has a candy jar, or you allow them to maybe use their phone, like I don't know, your organization may not allow it, but like, hey, if you go to every group today, I know I'm not supposed to, but I'll let you come into my office and we'll get your phone out of the shade and you can check your emails or something like that. You know, obviously monitor them and make sure that it's in line of your company's policies. But counselors can sometimes and should sometimes step outside of that box. You know, obviously there's ethics implied, but I mean, I've done that, you know, being a weekend counselor. Hey man, I know you're not my counselor, but can I use the phone? If the person's doing what they're supposed to do and they're going to group, like I'll let them do it. You know, but if they're being a shithead, I may not. 12-step facilitation therapy, widely used and effective. We know this particularly when you combined with other therapies like CBT. So yeah, it's a social support. It's a place where people can go. There's meetings all over the place and they incorporate a spiritual approach to recovery. It's a little bit more digestible for some people that may have some religious resistances or problems with like the higher power concept. Matt, appropriate for clients with opioid and alcohol use disorders. We talked about it. Clients with moderate or severe opioid or alcohol dependence who struggle with intense cravings and withdrawal symptoms. That can be a nice little bridge to kind of get them from day one to a place of stability where they can start incorporating other things. Most effective for, opioid and alcohol use disorders. Long-term effects shown to reduce relapse. And so this is just a summary of what we talked about. So if you want to skip those other slides and just kind of reference this, you can do that as well. So that is, we finished module 3. We're going to move into module 4 next week. So my plan is as follows. Do module 4. Module 4 is going to be a big one. I'm still building it right now, but I'm actually enjoying building it because I'm kind of relearning a lot of the stuff. I'm going to give I'm going to focus a lot. Like at first I thought I was going to focus a lot on like the specific ethics, like from the Texas Administrative Code and the NADAC Code of Ethics, which we're going to talk about that, but it's more of a practical approach. Like when is it okay to share confidential information without written consent? You know, like stuff like that. So hopefully you'll find it useful and beneficial. And then by Sunday, I will have your midterm review posted. So I'm about 60% done of it right now. It's literally, like I said, I'm building multiple choice questions directly from the PowerPoint slides. So it should be, I mean, they're honestly kind of easy. There's a couple of them that I think might stump you, but if you just know the PowerPoint, you'll be able to figure it out. So that's my plan for this week. Do you have any questions?
That's it. Well, I do have a question.
Yes, ma'am.
So I'm doing my discussion board, and can I talk about, like, we use the database called Columbus, the Clinical Management for Behavior and Health Services. And so my first time doing the screening was the other day. And so can I use that information, like what I experienced from that with the assessment and the screening?
Yeah,
Okay.
absolutely. Like, especially, I mean, I can't remember the exact, what was the prompt for discussion 3?
It's
I got it. Reflect on different models of addiction, explore cultural and evidence-based approaches.
See you next week. Thank you.
Bye, Chandra.
Bye.
Consider client assessment and treatment. Yeah,
no,
absolutely.
This was for 2. I'm still on 2.
Oh, my
I
bad.
got it wrote out though. I'm typing it up now. Yeah.
Yeah,
So,
absolutely.
but we use Columbus.
That's fine. Like I know I said identify and kind of like, I just gave you examples of the ones that we already went over.
Okay.
But as long as you can define and differentiate and like what the purpose of that was and what yeah, that's fine.
Okay, great.
You're good.
Okay, have a good day.
Bye, Kashima.
Bye-bye.